Thank you. Thank you, Ernest Bhai, and my respected moderator, panelist, and all the speaker next to me. My topic is heart failure management and overview. And after this, Athar sir has got the septal pacing tips and tricks. Uh, and other two speaker from India has got his bundle pacing and bundle left bundle pacing. So this is a very basic thing of heart failure management, and the terminal, that is the device therapy, that will be talked by the other speaker afterwards. So all the cardiac diseases lead to heart failure. There is a term, all the roads lead to Rome. Like all the heart disease ultimately lead to heart failure. So this is a very common disorders, and that is the destiny of all the diseases of the heart. So by definition, this is a complex pathophysiological state when the heart fails to maintain the adequate cardiac output, or can do so, that means maintain the cardiac output at a high left ventricular end diastolic pressure or LV filling pressure. So at that stage, it is called compensated heart failure. On the other hand, if it fails to do maintain the adequate cardiac output even in absence of even fails to do even at a raised EDP, that is called decompensated heart failure. Symptoms and signs and symptoms actually depends on congestion and hypoperfusion. Hypoperfusion produces fatigue. Congestion may produce the dyspnea if it is happens in the left heart failure, and congestion in the lung, and congestion in the liver, in the liver, that is the GI tract and lower limb, may produce the symptoms like congestive gastropathy, congestive hepatopathy. Classification is confusing. Sometimes it is classified as acute and chronic heart failure clinically, left or right-sided heart failure, sometimes high output and low output heart failure. And ultimately, there is newer terminology that is relatively newer, is the heart failure with reserved ejection fraction and heart failure with reduced ejection fraction. That is, heart failure with reserved ejection fraction, previously it was termed diastolic failure, but it is preferable term is the preserved ejection fraction, and reduced ejection fraction when the systolic dysfunction of the LV happens. So I will confine my topics to the heart failure with reduced ejection fraction. So this is the echocardiography, radionuclide, and CMR classification or nomenclature of heart failure with reduced ejection fraction when the ejection fraction is less than 40. If it is more than 40, the condition is termed as with normal ejection fraction or HEP. And in between 40 and 50 ejection fraction, this is termed mid-range ejection fraction, heart failure with mid-range ejection fraction. So heart failure classification of symptomatically, NYHA, and this is SEC and AHA guideline classification. We sometimes need to correlate between these two, stage A, B, C, and D with the class 1, 2, 3, and 4. Stage A, those patients at a high risk of developing heart failure. That is, there is a risk factor, but the patient is not symptomatic. On the other hand, if the patient has got a risk plus structural abnormality but no symptoms, that is the stage B. Stage T has got structural heart disease as well as symptoms, that may be the class 2 or class 3 symptoms, and stage D is the end stage of disease, class 4 symptoms. That means cannot perform any work without any discomfort. So management includes the firm diagnosis of the heart failure. That is very crucial before starting treatment. That should also exclude the heart failure mimicking condition like CKD, CLD, anemia, drugs, and some lung disease. Determination of the risk factor and etiology, precipitating factor, comorbidities, and severity of heart failure are also important. Precipitating factor that may include the poor compliance to the drugs and sometimes use of drug like non-steroid anti-inflammatory or steroid that may produce the water retention, anemia, obesity, arrhythmia, especially recent onset of atrial fibrillation or frequent ectopics, coronary artery disease, or progression of the disease pathology itself may precipitate the heart failure. It is a multidisciplinary approach, sometimes multiple comorbidity that may start from brain to leg. That may be the neurological, that may be the renal, that may be the hepatological, that may be related to the orthopathic, that may be related to the kidney disease always, sometimes. So rehabilitation and dietitian, these are two important things that should be approached in a different way. Ultimate objectives of heart failure is to reduce the mortality, so prolongation of the life, and morbidity means symptom, quality of life, increase the exercising capacity, and reduce heart failure hospitalization. So this is the simplified way ESC guideline 2016. First thing, if the patient has got any sign symptoms of heart failure and sign symptoms of congestion, so should be started with diuretics, either loop diuretics or thiazide diuretics. And second approach is ACE inhibitor and beta blocker. ACE inhibitor is the earlier choice than the beta blocker. We start with any patient with heart failure and symptoms. And if still the ejection fraction is less than 35%, then MRA may be the next option. If the symptom persists, then there may be need to switch over from ACE inhibitor to ARNI. If second thing that sometimes may needed is the CRT or device therapy. And if the heart rate is even higher than the 70 with maximal dose of beta blocker, or if the patient cannot tolerate the beta blocker, ivabradine is your choice. Sometimes ARNI can be used initially if the ejection fraction is less than 35, depending on the physician's choice, depending on the patient's condition and patient's economy, as well as availability of the drugs. Heart failure treatment algorithm. This is an easy way. The most of the patient that we get in our hospital and clinical practice is the stage C, where the patient is symptomatic as well as patient has already been having structural heart disease. So core cornerstone of therapy of stage C is the diuretics, either loop diuretics, ACE inhibitor or ARB beta blocker. MRA means mineralocorticoid receptor antagonist or aldosterone inhibitors, and newer group of drugs is HGLP inhibitors. All these drugs should be used and try to be combined all together to get the maximal effect of heart failure symptom reliefs. And if it fails, then we should go for revascularization, mitral valve surgery in some cases, and ultimately, if the condition is favorable for CRT, that is device therapy, either by CRTP or CRT or his bundle pacing. And ultimately, if all are resistant, the stage D, that is the refractory symptoms, that require special attention. And it has got higher mortality, 30 to 80% nearly. That may need inotropes for bridging support or symptomatic improvement, ventricular assist divide transplantation, and has got an ACE inhibitor, beta blocker, and mineralocorticoid receptor. Highest mortality benefit is with beta blocker, but for symptomatic relief, these two drugs are more important. Now, diuretics, loop diuretics is the initial choice. Sometimes we use loop diuretics along with adrenal inhibitor, but that care should be taken to add this mineralocorticoid if the serum creatinine is more than 2.5 and creatinine clearance is less than 30. And check potassium after 3 days. Painful gynecomastia may be the symptoms, especially in MRA group, then epinephrine is an option. ACE inhibitor, there is overwhelming evidence that benefit of ACE inhibitor in reducing the mortality, increase the longevity, and improve the symptom. Heart failure hospitalization indicated all patients with symptomatic, asymptomatic patient with ejection fraction less than 40. That should be started as low dose, that is true for beta blocker as well, and it should be increased gradually every 24 to 48 hours, or the beta blocker should be increased more gradually every 1 to 2 week interval. Higher dose of ACE inhibitor have got better benefit. That is true for beta blocker also. Higher the dose, better is the benefit. But it is better to treat with low or moderate dose of both ACE inhibitor beta blocker than highest dose of any one of these. Abrupt withdrawal of beta ACE inhibitor may deteriorate the symptom because of fluid retention from the kidney. Blood pressure, renal function, potassium should be monitored after 1 to 2 weeks. ARB is indicated only when ACE inhibitor is not tolerated due to cough, angioedema, or skin rash. Valsartan is the widely studied ARB. Aliskiren is a direct inhibitor. There is no evidence that proves the benefit, so it is not recommended. Hydralazine and nitrate are especially useful for African American black people. So this is the valsartan, and the other is the sacubitril or neprilysin inhibitor. These are the two systems of neurohumoral system. Renin-angiotensin system that is detrimental for the heart failure, and natriuretic peptide system that is useful, that is helpful for the heart failure. So this sacubitril that inhibits the neprilysin inhibition, means inhibits the degradation of these products, thereby it has got a beneficial effect. So if we use the valsartan, that is renin-angiotensin inhibitor and neprilysin inhibitor together, that has got synergistic and additive effect. So renin-angiotensin inhibitor and neprilysin inhibitor can modulate the neurohumoral system more perfectly and more completely than individual drugs, and that may reverse the ventricular remodeling. We know that ventricular remodeling that happens after acute hemorrhage, and that recovery or normalization sometimes may happen and sometimes may be in remission. It should not be started within 6 hours after stopping ACE inhibitor because of chance of angioedema. Three beta blocker commonly used on is metoprolol, which has got antiarrhythmic effect more than the anti-failure effect, and carbidopa is the most widely studied beta blocker in heart failure. And bisoprolol, it has got more selective effect on the heart, so more preferable in bronchial asthma and COPD patient. It should be started at low dose and titrated very slowly than ACE inhibitor, because initiation and increase in dosing may produce fluid retention due to abrupt withdrawal of adrenergic support from the heart and circulation. So better to start and optimize the diuretics before starting any beta blocker and ACE inhibitor. And combination of beta blocker and ACE inhibitor at lower dose that is tolerated is better than individual drug at higher dose. Even if with beta blocker heart rate remains 70, then ivabradine is a choice, especially in patients with low blood pressure and bronchial asthma patient. But it should not be used in patients with atrial fibrillation. Sometimes ivabradine may precipitate the atrial fibrillation. So SGLT2 inhibitor, this is a newer molecule for diabetic patient, but it has got many effects that not only reduce the hyperglycemia, but also effects in heart failure. So sometimes it is adjunctive to guideline-directed medical therapy in heart failure with reduced ejection. It has got anti-diabetic effect, cardioprotection effect, anti-failure, and renoprotection effect. It promotes the hepatic ketone synthesis. So this will provide energy to the heart. I will go in the next slide. So that is the effect of the diabetic. This is the diabetic nephron, and this is the diabetic nephron with SGLT inhibitor. SGLT inhibitor in the proximal convoluted tubule reduce the absorption of the glucose about 90% and sodium by about 10%. So more amount of sodium and glucose goes into the tubules and excreted. So that produces the diuretic effects, that produce the natriuretic effect. On the other hand, as it has got other effect, like when large amount of solute goes into the loop of Henle, active absorption is enhanced here, so more amount of oxygen is consumed and hypoxia happens in the tubules. And renal tubular hypoxia, that increase the secretion of, that is the erythropoietin. So that is helpful to stimulate the hemoglobin synthesis. On the other hand, there is a tubuloglomerular reflex that produces the apparent arterial vasodilatation, thereby it reduces the glomerular filtration rate. Though it is temporarily reduced glomerular filtration rate, it reduces the albumin area and it has got renal protection effects. So it has got three effects on its diuretic effects, that is the osmosis diuresis. Another is the renoprotection. Other effect is the erythropoietin secretion increase. It has got other effects in the liver also. In liver, it produces the ketone body, sometimes so that it may produce normoglycemic ketoacidosis. And these ketone bodies easily utilized by the mitochondria of the myocytes, so that with less oxygen consumption, more ATP is formed. That is helpful. Other way it may help is the sodium hydrogen exchanger in myocytes. That is, that produce usually myocyte injury and decrease mitochondrial calcium, thereby less ATP energy. In case of hypertension and diabetes, this exchanger system is expressed in the myocyte. So the SGLT2 inhibitor inhibits this expression of this system in the myocyte, thereby it reduces the injury to the myocyte and increase the ATP formation with less oxygen consumption. So device therapy, this is the ICD, CRTD or CRTP, and his bundle pacing and LV pacing. And ICD to prevent the sudden cardiac death in case of secondary prevention or in primary prevention with ejection fraction less than 35. And his bundle and CRT pacing that makes the QRS complex narrow, synchronize the ventricular contraction, so more slim, more getter looking. Wide complex always is bad prognostic sign in all cases. That may be the congenital heart disease, valvular heart disease, ischemic heart disease, or anything. So this is the ICD in heart failure. If we see NYHA class 2 and class 3 patient, sudden cardiac death is more common. Around 60% of the death happens from sudden cardiac death. On the other hand, those who are very critically sick, heart failure is the major cause of death. And sudden cardiac death due to sudden cardiac arrest only 33%. Other cause of death includes the stroke, that may be the renal failure, and that may be the multi-organ failure. So ICD is an important role, especially this group of patients with reduced ejection fraction to reduce the mortality. On the other hand, wide QRS complex has got association with sudden cardiac death and mortality. Wide QRS complex, whose complex QRS is more than 220, on-year mortality, on-year survival is around 60%, whereas those with normal QRS complex more than 90%. So it increases with wider QRS complex from on 100 millisecond to 220 millisecond increases, five-fold increases of death. And it is said that about 30 to 50% of the patients with heart failure have got some form of wide QRS complex and abnormal ventricular contraction. So ventricular dysynchrony produces the systolic dysfunction, diastolic dysfunction, sometimes mitral regurgitation because of papillary muscle dysfunction and dysynchronous contraction of the LV. So significant systolic improvement happens. So this dysynchrony is minimized either by CRT or his bundle pacing. And there is increase in LV ejection fraction, suppose 25 to 30%. It is apparently 5%, but absolute value is 20% improvement. Moreover, as the mitral regurgitation is reduced, forward stroke volume is reduced. That is important to improve the symptom of the patient. So these are the CRT that includes the lead in the RP, lead in the LV through the coronary sinus, that reduces the all-cause mortality, that reduce by 40%, reduce the heart failure mortality by about 45%, and sudden death by about 46%. And it is indicated in all patients NYHA class 2 to class 4 ambulatory with ejection fraction less than 30%, 35% after 3 months of guideline-directed medical therapy, NYHA class on with ejection fraction less than 30% also, and LVB QRS duration more than 150 millisecond with normal sinus rhythm. In some cases, it is also helpful. And if life expectancy is more than 1 year. So with this, I like to thanks the organizer. I like to thanks all the audience for attention.
স্যার কাইন্ডলি আনমিউট করবেন প্লিজ। নাসিরউদ্দিন স্যার প্লিজ কাইন্ডলি আনমিউট করবেন।
You hear me?
Yes, we can hear you, sir.
My net is disturbing. Hello?
We can hear you. We can hear you, sir.
Okay. Thank you, Dr. Ashok, for your nice deliberation. Starting from pathology, pathogenesis, and drug to device. May I request for taking 1, 2, 3 questions from the panelists? I like to request Professor Atar Ali to be the moderator of this session also. Atar Ali, sir?
Yes, thank you very much, Nisar. I can hear you. And really, it was a very excellent talk by Dr. Ashok Kumar. He covered all the things, and I think it was very much useful for today's session also, as because today's all the lecture is a beautiful session. That is all kinds of the pacing therapies, and all the pacing therapies are related with the brain as well as the heart failure. So it was an excellent talk by the Dr. Ashok Kumar. Thank you very much, Ashok Kumar. And I can invite from the participant, dear participant, you can ask any questions, and you can even you can send your question to the chat box.
Ashok, can I ask one question, please, from the audience? Hello? Dr. Ashok, can you unmute?
Yes. Dr. Mohsin Bhai is also here.
Yeah. Any question from the panelist?
Mohsin, are you here?
Mohsin is here. Dr. Mohsin?
Yes.
Dr. Ashok, one simple question, especially for the working doctor who are working the ward. How can we start arnigen, especially for the low blood pressure patient having low blood pressure? And another question is particularly, do you have any special superiority of any particular beta blocker, anything else? And third question is, how can we start medication, especially low blood pressure with congested patients, that is a wet heart failure patient?
So
virtually 3 questions for you.
You have got 3 questions. One is all are with low blood pressure. So this is actually very much a headache for all the cardiologists to give the medication of heart failure patient with low blood pressure. To reduce the heart rate, beta blocker also reduce the blood pressure as well. So it is a very difficult issue. ARNI can be used with very low dose. So the recommended dose is 100 to 200 milligram, but rarely our patient can tolerate such a low dose, higher dose. So sometimes we use 50 milligram on foot. Sometimes we start with like this, and gradually we try to titrate that dose. Sometimes we use the dose at bedtime only, and subsequently NBD dose. And in any weight patient, diuretics, loop diuretics is the first choice of drug. And if the renal function is not is good, then loop diuretics with potassium sparer in combination or in IV preparation we can use loop diuretics in IV preparation and potassium sparer in oral preparation. What was the other question?
But do you have any special
beta blocker regarding beta blocker? Carbidiol is the, I think, most widely studied beta blocker that is very much useful as an failure and anti-failure and antihypertensive. Metoprolol has got superiority in case of arrhythmia in any patient. And bisoprolol I always prefer in patient with those who have active bronchial asthma or those who have a history of bronchial asthma or COPD like this.
Sometimes patients
any opinion from Dilip Kumar or Atar sir?
Dilip Kumar, please.
Hello, sir. Good to be
regarding beta blocker. Do you
Any
have any
choice of
special,
beta blocker?
Yeah.
special choice or superiority
Whereas,
to?
I think we have been using more of bisoprolol. There are 2-3 merits. One is the titration is very easy. You have only titrated to 3 doses: 1.25, 2.5, 5, and then 10. For metoprolol, reaching to 200 milligram, it is a big task, and many times we give only 25, 50, and then we stop there, and it may not be the target dose. Second is bisoprolol is more selective, and the antihypertensive response is quite robust. And I think these are the benefits bisoprolol we are giving. And finally, in dialysis patients, in hemodialysis patients, the bisoprolol response is much better than metoprolol. So altogether, if you put it all together, bisoprolol seems to be number one choice.
Is there any superiority of bisoprolol to reducing heart rate of what the other beta blockers? Dr. Dilip?
Yes, sir. In CBIS2 trial, the average heart reduction was 14 as compared to 11 with metoprolol, and carbidopa. It is difficult to measure because of alpha blockage and beta blockage. So carbidopa is we are opting less. So the most robust heart rate reduction is with bisoprolol.
May I ask one question?
In heart failure, Ashok, in heart failure, metoprolol succinate is the drug to be chosen, not the normal
tartarate.
Yeah.
Yes. Metoprolol has got disadvantage
Metoprolol
because sometimes
metoprolol succinate has the
we have to use at least 2 times, sometimes 3 times in a day. That is disadvantage. Bisoprolol has got advantage over.
Metoprolol succinate is single dose. Metoprolol succinate extra formulation.
That should be the sustained release preparation only.
Yeah, extra formulation, extended release.
But anyhow, Dilip Kumar and Athar sir, any mortality benefit, which one is higher regarding all the study, bisoprolol or metoprolol or carbidopa? Mortality benefit.
Actually,
mortality benefit with bisoprolol was 44% in CBIS2, and after CBIS2, the beta blocker came as indication for heart failure. This was the landmark.
Yes.
Before CBIS2, it was CBIS1, merit heart failure, and the Copernicus was also already out. And with metoprolol, it was 36%. So there are some variations. Maybe all these 3 are recommended, but gradually I think there is one more benefit. Bisoprolol is even at 2.5 milligram, there was significant reduction in mortality. Unlike in metoprolol, when we have to reach a target dose of at least 150 or 200 to get mortality benefit.
What about the SGL2 in heart failure in your private practice? SGL2 and ARNI?
We have been using a lot of ARNI for last 3-4 years. Now we have started SGLT2 in all patients who are even non-diabetic but having heart failure. But first we start ARNI, and then we step up with SGLT2.
Dr. Dilip, how can we use beta blocker, especially for heart failure with hypertension patient? Which beta blocker should we prefer?
Again,
in our daily practice.
Both these bisoprolol and metoprolol as an antihypertensive we can use.
And if there is a concomitant arrhythmia, which one?
Arrhythmia, I think they can't put a particular choice. Both have been shown to reduce certain cardiac death.
Just I want to know precisely for the junior doctor, those who are working in the ward.
So precisely, I tell bisoprolol looks to be more kind of efficient medicine.
Yeah, carbidopa has got least antiarrhythmic effect.
Dr. Nesar.
Yeah, sir.
Actually, pharmacologically, that is the carbidopa blocks both the alpha and the beta receptor, so it is more antihypertensive than the bisoprolol. Bisoprolol is more, and what is actually told by the Dilip Kumar, actually, if the study we see mortality benefit, it is the bisoprolol. If the blood pressure is the target, then the carbidopa should be better. If the arrhythmia is target, there are lots of studies related with the metoprolol. Then the other, so it is the that is metoprolol. So you have to fix the target for which purpose you want to use the beta blocker, and then you have to select the drugs, I think.
So any question from our other panelists, Dr. Mohsin and Jamil Bhai?
No, Ashok has outlined nicely in every corner of the management of heart failure. No further question. Please proceed.
Sir.
Dr. Sundaram? Dr. Sundaram, do you hear me?
Yes, sir. Good evening, sir. How are you?
Do you have any comment, please?
No, nothing, sir. I think the role of beta blocker has been well discussed. So, I think, yeah, about Dilip Kumar sir was saying, the problem of metoprolol is achieving a target dose. So, we usually prefer this Corbis as a better choice over this metoprolol. I think it's well discussed. We can move on to the next topic, sir.